Hello, this lecture covers maternal hypertensive disorders, chapter 12 of your textbook. These are the learning objectives. Please take the time to review these objectives as you review the lecture contents. Now let's take a look at the significance and incidence of these hypertensive disorders. Hypertensive disorders in pregnancy is a common medical complication of pregnancy. Hypertensive disorders are a major cause of perinatal morbidity and mortality globally due to the following: uteroplacental insufficiency and premature birth. Of maternal deaths worldwide, 10 to 15% can be attributed to preeclampsia and eclampsia. And these are the major hypertensive disorders that we're going to cover in this lecture. Preeclampsia accounts for more than 50,000 maternal deaths each year. A stillbirth rate of women with preeclampsia with severe features is about 21 in every 1,000 pregnant women. And so this is very, very alarming. Let's look at the morbidity and mortality associated with hypertensive disease in pregnancy. With regards to morbidity, there is a high association with renal failure, coagulopathy, cardiac or liver failure, placental abruption. And this placental abruption is one of the key topics that we're going to cover in this course. Placental abruption has a higher association with preeclampsia and any of these hypertensive disorders in general. Seizures is also another morbidity, along with stroke. Mortality: well, pregnancy-related hypertension accounts for 10 to 15% of maternal deaths worldwide. This is something that is very, very personal to me because 2 years ago I lost my maternal cousin due to placental abruption secondary to severe preeclampsia. So this is something that is so close to my heart. This is the reason why it is important to create awareness with regards to these hypertensive diseases in pregnancy and ways to prevent them or to manage patients who have hypertensive disorders. Hypertensive disease in pregnancy is divided into clinical subsets of the disease based on end organ effects and progresses along a continuum from mild gestational hypertension, mild and severe preeclampsia, eclampsia, and HELLP syndrome. And the HELLP syndrome means hemolysis, elevated liver enzymes, and low platelets. So these are the various classifications of hypertensive disorders: gestational hypertension, preeclampsia, chronic hypertension with superimposed preeclampsia, and HELLP syndrome. And we're going to cover these one at a time. Gestational hypertension, or gestational hypertension, which begins after the 20th week of pregnancy, describes hypertensive disorders of pregnancy whereby the woman has an elevated blood pressure at around 140 millimeters of mercury over 90 millimeters of mercury or greater, and this is recorded on 2 different occasions for at least 4 hours apart. So the onset of this gestational hypertension is usually around 20 weeks. So after 20 weeks of pregnancy, so you have a patient who never had a history of hypertension, and now after 20 weeks, the woman starts to develop elevated blood pressure. The blood pressures are systolic is greater than 140, diastolic greater than 90. That is a definition of gestational hypertension. So with this gestational hypertension, there is no proteinuria or other systemic findings that are diagnostic for preeclampsia. So you have high blood pressure without proteinuria or other systemic findings that are consistent with preeclampsia diagnosis, and that is after 20 weeks of pregnancy. Usually, this gestational hypertension will resolve by week 12 during the postpartum period. So now let's look at another classification of hypertensive disorders known as preeclampsia. Preeclampsia is a pregnancy-specific condition in which hypertension and proteinuria develop after 20 weeks of gestation in a previously normotensive woman. A normotensive means that this woman had no elevated blood pressure whatsoever. She had no history of high blood pressure. All of a sudden, after 20 weeks of gestation, she becomes hypertensive and she now has proteinuria. So when this happens, you have a diagnosis of preeclampsia. Also, in the absence of proteinuria, preeclampsia may be defined as hypertension along with one of the following: thrombocytopenia, impaired liver function, new development of renal insufficiency, pulmonary edema, new onset cerebral or visual disturbances. So, in other words, it means that if your patient has high blood pressure, even if they didn't have proteinuria, if they have thrombocytopenia with hypertension, you have a diagnosis of preeclampsia. So any one of these, along with hypertension, will rule a patient in for preeclampsia. Preeclampsia can be mild or severe. A mild preeclampsia is defined as gestational hypertension with the addition of proteinuria of greater than or equal to 1+. A patient with mild preeclampsia can report of transient headaches which might occur along with episodes of irritability. And the patient may also complain of edema. So edema can be present in mild preeclampsia. Normally, during pregnancy, edema below the waistline is normal. However, edema above the waistline or generalized edema is a concern, and that's usually a classical symptom or manifestation of preeclampsia. On the other hand, severe preeclampsia consists of blood pressures that is 160 over 110 millimeters of mercury or greater, proteinuria greater than 3+, oliguria, elevated serum creatinine greater than 1.1 milligram per deciliter. Also, things like cerebral or visual disturbances, headaches, and blurry vision may accompany elevated blood pressures in severe preeclampsia. Hyperreflexia with possible ankle clonus may be present. And so this clonus is a neurological condition that causes involuntary muscle contractions resulting in uncontrollable shaking movements. So in order to find out if your patient has clonus present, you want to ask a patient to dorsiflex her foot, hold the foot with a slight tension with the toes pointed towards you, the examiner. On releasing the foot, if it jerks over 5 times, it is a clonus reaction, and that is a sign usually that there is an impending seizure episode or activity. Also, with severe preeclampsia, there might be pulmonary or cardiac involvement, extensive peripheral edema, hepatic dysfunction, epigastric and right upper quadrant pain, and thrombocytopenia. Eclampsia. Eclampsia is a seizure or severe preeclampsia manifestations with the onset of seizure activity or coma. So with eclampsia, there is onset of seizure activity or coma in a woman with preeclampsia. So that is worsening preeclampsia. And the differences between the two, or the difference between preeclampsia and eclampsia, is that in preeclampsia, pre means before seizure. So in preeclampsia, the woman has not had a seizure activity. In eclampsia, she has ceased. There is presence of seizure. So seizure is the difference. The presence of seizure in eclampsia is what differentiates eclampsia from preeclampsia. Eclampsia is usually preceded by headache, severe epigastric pain, hyperreflexia, and hemoconcentrations, which are warning signs of probable convulsions or seizures. And also with eclampsia, there is no history of pre-existing pathology. About 50% of eclamptic women develop the condition while pregnant. In addition, women can develop eclampsia in the immediate postpartum period. I had a patient one day, and this patient delivered a baby. It wasn't even up to 5 minutes after delivery. Placenta delivered. So 5 minutes after the baby came out, her placenta was about to deliver. The placenta wasn't even out yet. So the placenta was about to deliver, and then this woman started seizing. It was so traumatizing. The way the jerking movement, we had to pull the emergency bell. So yes, women can develop eclampsia in the immediate postpartum period, usually right before the placenta is delivered, or immediately after the delivery of the placenta, they will have the eclampsia or the seizure. Chronic hypertension. So what is the difference between chronic hypertension and chronic hypertension with superimposed preeclampsia? Well, we're going to find out. Well, chronic hypertension is hypertension that is present before pregnancy. So this woman, before she got pregnant, she already has hypertension. It can also be diagnosed before week 20 of gestation. Sometimes we might be running around with high blood pressure. We don't know that we have it. So if a woman is pregnant and she goes to her first prenatal appointment, usually probably like around 8 to 12 weeks, and this woman has high blood pressure, so her pressures were high, and then the doctor will probably say, you know what, we'll check this again when you come back. Or they could tell the patient to buy a blood pressure kit at home and check it. So now the patient comes back again for her next prenatal visit, which is usually 4 weeks after the first one. So the patient comes back. So let's say now she's 16 weeks gestation and her blood pressures are high again. So now after 4 hours interval, you recheck it again, it's still high. That woman has chronic hypertension because she's not even up to 20 weeks. But if she makes it to 20 weeks and never had high blood pressure, then it is a gestational hypertension. What about the chronic hypertension with superimposed preeclampsia? Well, women with chronic hypertension may acquire preeclampsia or eclampsia. So a woman who has chronic hypertension, if she now has proteinuria with chronic hypertension, that is known as chronic hypertension with superimposed preeclampsia. And these can be really difficult to diagnose. So now let's look at the etiology of preeclampsia. This is a condition that is unique only to human pregnancy. So if you're not pregnant, you will never have the diagnosis of preeclampsia. No single profile identifies risk for gestational hypertensive disorders. However, there are some high risk which includes the following: maternal age younger than 19 or older than 40 years, first pregnancy with a new partner, morbid obesity, history of preeclampsia, could be a family history or a prior history of preeclampsia, pregnancy onset snoring, multi-fetal gestation, chronic renal disease, chronic hypertension, diabetes, rheumatoid arthritis, and systemic lupus erythematosus. These are some of the risk factors associated with preeclampsia. The cause of preeclampsia remains unknown. However, there are many theories surrounding preeclampsia. Although the pathophysiology of preeclampsia remains unclear, the placenta is at the root cause. There are key features that involve uterine spiral arteries, and so the failure to transform from thick-walled muscular vessels to thinner sac-like flaccid vessels, which increases blood volume capacity of the vessels, is at the root cause. There is another root cause which has to do with maternal vasospasm. Vasospasm contributing to poor tissue perfusion is the underlying mechanism for the manifestation of pregnancy hypertensive disorders. So this maternal vasospasm leads to decreased perfusion to all organs, including decreased placental perfusion. Increased platelet activation by endothelial cells, more sensitive to pressure agents, decreased renal perfusion. Low dose aspirin may result in modest risk reduction, and also preeclampsia affects the growing fetus. It could lead to what is called IUGR, and this IUGR means intrauterine growth restriction. It can restrict the growth of the fetus in utero. So now let's look at the algorithm of preeclampsia. So when a patient has preeclampsia, remember in the previous slide we talked about the role of vasospasm. So that vasospasm and decreased organ perfusion will cause hypertension. So you have hypertension, and then uteroplacental spasm as a result of vasospasm will lead to IUGR, which is intrauterine growth restriction. Also, with vasospasm and decreased organ perfusion, you will have the glomerular damage. In turn, the glomerular damage will cause increased plasma uric acid and creatinine, also causing oliguria. And this oliguria is if you're making urine less than normal. So if you have a patient who in 24 hours only puts out a urine output of 400 cc's, that is classic oliguria. Vasospasm and decreased organ perfusion can also cause cortical brain spasm, and this cortical brain spasm will give rise to headaches. So that is why the patient will complain of headaches. You will see hyperreflexia and seizure activity as a result of cortical brain spasm. Retinal arteriolar spasm will cause blurred vision or scotomator, and this scotomator is seeing spots right before your eyes, and that is a sign of worsening preeclampsia. So when you look at all this, these are symptoms that the patient who have preeclampsia will complain: headaches, blurry vision, oliguria, hypertension. So these are all the signs and symptoms of preeclampsia. And of course, there will be hyperlipidemia secondary to vasospasm and decreased organ perfusion. Liver ischemia will also be a result of vasospasm, and that will now result to elevated liver enzymes, nausea, vomiting, epigastric pain, or right upper quadrant pain. So that is due to liver ischemia. Intravascular coagulation is also another problem that could cause hemolysis of red blood cell, platelet adhesion, increased factor VIII antigen, and these will result to low platelet count, known as thrombocytopenia. And with thrombocytopenia, it will consequently lead to DIC, and DIC stands for disseminated intravascular coagulation or coagulopathy. Finally, increased permeability and capillary leakage will cause proteinuria. So that is why the patient is now spilling protein into her urine because of that increased permeability and capillary leakage. This will also give rise to generalized edema that we mentioned at the onset. Pulmonary edema will cause dyspnea. So the patient is huffing and puffing, shortness of breath. Hemoconcentration as a result of increased permeability and capillary leakage will give rise to increased hematocrit. So this is the algorithm for preeclampsia. So once again, the hallmark signs of preeclampsia includes hypertension, oliguria, headaches unrelieved by Tylenol, blurred vision, scotomator, nausea, vomiting, or right upper quadrant pain or epigastric pain, elevated liver enzymes, dyspnea. Of course, you will have edema. So now let's shift our focus to HELLP syndrome. What is HELLP syndrome? Well, HELLP syndrome is a variant of gestational hypertension in which hematologic conditions coexist with severe preeclampsia involving hepatic dysfunction. HELLP syndrome is diagnosed by lab tests, not clinically. So you have lab tests that is an indication of that HELLP syndrome. H stands for hemolysis, EL for elevated liver enzymes, LP for low platelets. And so with hemolysis, this results in anemia and jaundice. So your patient will become anemic, severely anemic and jaundiced as a result of being in HELLP syndrome. Elevated liver enzyme will result in elevated liver enzymes such as the ALT or alanine aminotransferase, aspartate transaminase. It will also cause epigastric pain, nausea, and vomiting. Low platelet, on the other hand, which is when your platelet count is less than 100,000. Normally, the normal platelet is 150,000 to 400,000. So during pregnancy, the platelet may drop a little bit. But if you have a woman who is pregnant and her platelet is less than 100,000, that is thrombocytopenia, and that is an indication of low platelet count. So this low platelet will result in thrombocytopenia, abnormal bleeding and clotting time. The patient will have bleeding gums, petechia, and possibly DIC, which is disseminated intravascular coagulopathy. HELLP syndrome occurs in 0.5% to 0.9% of all pregnancies. About 10 to 20% of women who have preeclampsia with severe features do develop HELLP syndrome. So if your patient develops HELLP syndrome, you really have a sick patient, and this patient needs a collaborative effort in order to care or to treat the patient and manage her care. HELLP syndrome can also be as a result of arteriolar vasospasm, endothelial cell dysfunction with fibrin deposits, and adherence of platelets in blood vessels. The clinical presentation is often nonspecific. However, most women with the disorder do report the following, as I mentioned in the previous slide: history of malaise, and that is feeling of unwell. They may report influenza-like symptoms, epigastric or right upper quadrant pain. The symptoms may worsen at night and improve during the daytime. Care management. The ultimate goal is to identify and prevent preeclampsia. Currently, there is no reliable test or screening tool which has been developed. However, low-dose aspirin, 60 to 80 milligrams, may help certain high-risk women. There are potential biomarkers that are being investigated, and that is the tyrosine kinase and serum placental growth factor. Abnormal uterine artery Doppler velocimetry in the first and second trimester of pregnancy is also being investigated to see how effective it is in identifying and preventing preeclampsia. In your management of patients with any of these hypertensive disorders, it is always important to use your nursing process. And so in assessment, you want to make sure that you accurately measure the blood pressure. And it is also important to make sure that you're using the right cuff size to measure the blood pressure of the patient. Assessment of edema is also essential, although the presence of edema is no longer included in the definition of preeclampsia according to the new update, but in the word of NCLES, it is still counted as the hallmark symptoms of preeclampsia. Deep tendon reflexes need to be assessed. You also want to assess for hyperactive reflexes or clonus. Proteinuria ideally is determined by evaluation of a 24-hour urine collection. So we'll give the woman a 24 urine hour collection container to collect her urine for the entire 24 hours, and then she brings it in and we'll send it to the lab. It's very important to evaluate for signs and symptoms of severe preeclampsia, which includes headaches, epigastric pain, right upper quadrant pain, and visual disturbances. So the patient who calls the clinic and say to the nurse, "Hey nurse, I just woke up this morning. I don't wear glasses, but I've been having blurry vision. I feel like I'm seeing sparks before my eyes." What will the nurse tell the patient? Well, obviously, a prudent nurse will say to the patient, get yourself to the nearest emergency room or come to the labor and delivery unit immediately, because that nurse recognizes that those are the signs of severe preeclampsia. Or the patient complains of epigastric pain. Sometimes the patient confuses it to be heartburn. So if a patient says, I'm having this severe heartburn, please tell her to come in and be assessed. It could have been a sign of worsening preeclampsia. Mild gestational hypertension and preeclampsia without severe features can be managed at home. And so the goal of therapy is to ensure maternal safety and deliver a healthy newborn close to term. This is a patient who will benefit from home care. So the visiting nurse may be visiting the patient or home care nurses. Also, you have to do maternal and fetal assessment. Activity restriction may be implemented depending on how the patient feels. Diet, you want to put the patient on a low sodium diet, nothing more than 2 grams of sodium in a day. So the goal again is to ensure maternal safety and deliver a healthy newborn close to term. Gestational hypertension and preeclampsia with severe features. Goals of care are to ensure maternal safety and to formulate a plan for delivery. During the intrapartum period, your intrapartum care will include putting the patient on bed rest with side rails up. Remember, you know that there is a possibility that this patient may have a seizure, so you want to maintain patient safety. Put them in a room that is darkened, so a darkened environment is ideal. Magnesium sulfate therapy is initiated in these patients, and the reason why we start them on magnesium sulfate is to prevent them from having seizures. So magnesium sulfate therapy is started or initiated in our patients with preeclampsia with severe features in order to prevent seizures. Along with magnesium sulfate therapy, antihypertensive medications are given to patients. So medications such as beta blocker, labetalol, is given to reduce or to lower the blood pressures. Now, if the labetalol, which is a beta blocker, fails to reduce the patient's blood pressure, hydralazine or apresolin will be given in order to reduce the blood pressures, because you don't want the patient to have a stroke. So once again, the intrapartum care includes magnesium sulfate therapy and antihypertensive medication, putting them in a darkened environment to decrease stimuli, and making sure that they are on bed rest with side rails up, and if possible, to pad the side rails. During the postpartum period, your postpartum care includes still monitoring the blood pressures, the vital signs, checking for deep tendon reflexes, the level of consciousness. About 30% of cases of eclampsia and HELLP syndrome do occur during the postpartum period. So that is why close monitoring is still important during the postpartum period. You also want to monitor for bleeding, because patients who are preeclamptic are unable to tolerate excessive blood loss. So you have to keep an eye on that fundus if your patient had preeclampsia. Future health care. Well, these women who had hypertension or hypertensive disorders are sevenfold risk or have sevenfold risk of developing preeclampsia or eclampsia in a future pregnancy. So they definitely need an education about that. They are also at increased risk of adverse perinatal outcomes. So you really want to educate them well. Now, if you take a look at this image, you will see the patient who is preeclamptic, and this patient is getting IV infusion with magnesium sulfate. Also, with these patients who is on magnesium sulfate, you have to make sure that they are placed on a cardiac monitor. So you see the cardiac monitor. The reason why you have to put them on a cardiac monitor is because you have to check monitor their cardiac, the heart rate. You want to monitor their respiratory rate, the blood pressure. Now, if a patient is on magnesium sulfate, this is very important. you need to remember that your patient who is on magnesium sulfate can become toxic from magnesium. Magnesium has a narrow toxicity window, or it has affinity with the kidneys. And this is why once your patient is on magnesium sulfate, you need to insert a Foley catheter on them so that you can keep an eye on their intake and outputs. Urinary output measurement is very, very essential, because one of the ways to identify that a patient is becoming toxic from magnesium sulfate is if the patient has a decreased urine output. So decreased urine output is the sign of magnesium sulfate toxicity. Magnesium sulfate is a respiratory depressant, so that is why you need to monitor their respiratory rate. If your patient is on magnesium sulfate therapy, you need to keep an eye on their respiratory rate. You know that normal respiratory rate is 12 to 20. So now if you look at this monitor, you're seeing a respiratory rate of 10. That is not normal. So this is a sign of magnesium sulfate toxicity. Decreased respiratory rate. That is a sign of magnesium sulfate toxicity. What will you do if you notice that your patient who is on magnesium sulfate now has decreased respiratory rate? Well, you need to shut the freaking magnesium off. Turning off the magnesium will be the most important thing that you need to do as a nurse. Another sign of magnesium sulfate toxicity is decreased level of consciousness. So decreased level of consciousness is also a red flag. It is a sign that your patient is becoming toxic from magnesium sulfate. Now the patient, remember we said hyperreflexia is one of the signs, right? If they are on magnesium sulfate and they are toxic, the patient will now have absent deep tendon reflexes. So you see the little hammer thing, and you're assessing the deep tendon reflexes. Once it is absent or decreased, that is a red flag. That is a sign that the patient is becoming toxic. And of course, if you send lab values to monitor the magnesium level, the lab values will definitely be elevated. Normally, our magnesium level runs about 1.5 to 2.5 milliequivalent per liter. However, if your patient is on magnesium sulfate for therapy, we're looking for what is called the therapeutic range. So the therapeutic level for magnesium sulfate therapy, it will be about 4 to 7 milliequivalent. So if your patient's magnesium level is more than 7, that is a problem. So once you see that, you need to stop the magnesium sulfate. Stopping the magnesium sulfate, once again, is one of the most important things that you want to do as a nurse once you identify that there is a problem. So the therapeutic range for serum magnesium level, once again, is 4 to 7.5 milliequivalent. So it's 7.5, not 7. So serum magnesium level therapeutic range is 4 to 7.5 milliequivalent. So anything more than 7.5 will be a sign of toxicity, and turning off the magnesium sulfates will be the ideal nursing intervention. Once again, to recap, your patient who is on magnesium sulfate, you need to keep an eye on them. Monitor their urine output. Place them on a cardiac monitor, because you know that magnesium is a respiratory depressant, that if their respiratory rate drops below what is normal, that is a sign of magnesium sulfate toxicity. You also know that if there is an absent deep tendon reflexes, that it is a sign of magnesium sulfate toxicity. Decreased level of consciousness, decreased urine output. And by the way, the normal urine output per hour on the average should be at least 30 cc's per hour. Your patient who is on magnesium sulfate, their urine output for the past 3 hours is only at 30. That is not a good thing. That magnesium sulfate must be turned off. So these are the key things to remember when you are managing a patient who is pre-eclamptic with severe features that is needing magnesium therapy. And the antidote for magnesium sulfate toxicity is calcium gluconate. The antidote for magnesium sulfate toxicity is calcium gluconate. So you want to make sure that you have this medication on hand should the doctor want to give it. So if the doctor wants to administer calcium gluconate, you need to make sure that it's available as the nurse. But this is an emergency medication that is given to counteract the effects of magnesium sulfate. So this is the antidote for magnesium sulfate toxicity. Another key thing about magnesium for you to remember is that not all patients who are pre-eclamptic with severe features are candidates for magnesium sulfate. You don't give magnesium sulfate to the following patients. Patients with end-stage renal disease should not be receiving magnesium sulfate therapy. Magnesium sulfate is contraindicated in the setting of a patient who has an end-stage renal disease. A patient with pulmonary edema will not be a candidate for receiving magnesium sulfate. In your patients who have end-stage renal disease, the kidneys aren't working, so why will you give them magnesium sulfate? Unless you want to commit euthanasia. That's a nice way of putting a pillow over their head and killing them. So when your patient has end-stage renal disease, keep magnesium sulfate away from them. If they need something for prevention of seizures, Dilantin may be the drug of choice, because Dilantin is an anticonvulsant. So you could give them something to prevent them from seizing. Pulmonary edema. In pulmonary edema, the patient is already huffing and puffing. So if you give them magnesium, that's a nice way of euthanasia. You want to kill them. So please do not give magnesium to a patient who has pulmonary edema. That would depress their respiratory system. Also, magnesium sulfate is contraindicated in patients who have myasthenia gravis. Patients with myasthenia gravis are not candidates for magnesium sulfate. And the last but not the least is hypocalcemia. You do not give magnesium to patients with low calcium level. Hypocalcemia is a contraindication for magnesium. Remember, calcium and magnesium are inversely related. If your calcium is low, it will cause your magnesium level to become high. So that will cause magnesium toxicity if you give it. So those are the key things to remember when you think about magnesium sulfate in the management of preeclampsia. Let's look at the eclampsia interventions. Well, immediate care, you have to assess for those premonitory signs such as persistent headache, blurry vision, epigastric pain, right upper quadrant pain. If there is altered mental status, you want to pick it up immediately. Convulsions, so if the patient starts to seize, the most important thing you want to do is to make sure that your patient is safe. The safety of the patient is very essential in the presence of a seizure activity or in the setting of a seizure activity. Ensuring that the airway is patent is also important. Patent airway is very, very essential. You want to ensure that your patient's airway is patent. This is not a time to stick anything inside the patient's mouth. Do not put in a tongue blade on the patient, inside the mouth of a patient who is having a seizure. And of course, maternal stabilization is important. Chronic hypertension. Well, these affect 4% to 5% of pregnant women. Ideally, the management of chronic hypertension in pregnancy begins before conception. So you want to make sure that their hypertension is stable even before they conceive. Chronic hypertension is associated with increased incidence of the following: abruptio placenta, as I mentioned before, superimposed preeclampsia, increased perinatal mortality, IUGR, and preterm birth. So this is why you want to make sure that is under control before the patient even conceives. These are some of the complications that are associated with Chronic hypertension. During the postpartum period, the patient may develop pulmonary edema, renal failure, heart failure, encephalopathy. These are complications associated with chronic hypertension. Question. A 36-year-old, client at 36 weeks of gestation presents to labor and delivery complaining of a constant headache for the past 2 days. She also states that her face seems more swollen than usual. What should be the nurse's first action? Well, the correct answer is D. The nurse's first action will be to take the client's pressure. And so this is the end of hypertensive disorders in pregnancy.